Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by independent funding from Novartis.
This program is presented by Medscape Education Global.
Hello, I'm Athanasios Djoufas. I'm a professor of rheumatology and pathophysiology in the School of Medicine at the National and Kapodistrian University of Athens in Greece. Welcome to this program entitled Addressing Unmet Needs in the Management of Sjögren's Disease, a spotlight on emerging biologic therapies. I'm pleased to be joined today by Thomas Dörner, Professor of Medicine in the Department of Rheumatology and Clinical Immunology at the Charité Medical University in Berlin, Germany. Also pleased to be joined by Sarah McCoy, who is Assistant Professor in the Department of Medicine and Division of Rheumatology at the University of Wisconsin in the United States. A very warm welcome to you both, my friends, Sarah and Thomas. Sarah, can you set the stage for us and describe the unmet needs for patients with Sjögren's disease?
I would love to. So it's exciting to be here today to speak to everybody. So Sjögren's disease, what makes it unique? Well, it's one of the most female predominant systemic rheumatic diseases that we see in clinic. You could argue maybe it vies neck and neck with lupus, but we Sjögrenologists think that it's the most female predominant. And the average age of onset is typically around the time of perimenopause. And the interesting thing about Sjögren disease is it actually has a bimodal onset. So there's this perimenopausal time of onset where most people have onset of their disease. And there's an earlier peak that occurs around the time of menarche. And those patients who get earlier disease onset tend to have more severe disease. Additionally, Sjögren disease has significant symptomatic burden. So our patients who present with severe symptoms have marked increase in healthcare costs, twice that of control patients. And they also have reduced healthcare quality of life. So here on the left side graph, you can see United Kingdom Sjögren's data in black bars and the general population in white, and that healthcare related quality of life related to anxiety, depression, pain, usual activities, self-care, and mobility are markedly worse in Sjögren disease than their control comparators. So what leads to this reduced quality of life and increased healthcare costs? Well, it's typically driven by symptom burden. And Sjögren's particularly has a heterogeneous range of symptoms. This ranges from the hallmark features of dry eye, dry mouth, fatigue, and pain to a gamut of other symptoms like dry or itchy skin, morning stiffness, photosensitivity, or forgetfulness. We try to capture these symptoms through something called the ESPRI, which is a patient-reported outcome that gives the three hallmark symptoms, dryness, fatigue, and pain, in a visual analog scale ranging from 0 to 10. And the patient is supposed to recall the last 2 weeks of symptoms in these three domains and rank them from 0 to 10. Now, of course, Sjögren's doesn't just involve the glands. It has a lot of other organ systems that can be involved. This ranges from the lungs, so we can get xerotrachea. We can get bronchial or larger airway involvement in the form of bronchiectasis or bronchiolitis. We can see an asthma-like disease. Instead of an eosinophilic-related process, it's more of a desiccation-related process. And we can see interstitial lung disease, of which LIP is the most specific for Sjögren's disease. Renal involvement is common when you start looking for it. We can see renal tubular acidosis, glomerulonephritis, and interstitial nephritis. Gastrointestinal involvement is also quite common. We can see gastroparesis. Rashes are common in Sjogren disease, along with dry skin. We can see peripheral nervous system involvement, central nervous system involvement, and then we can see associated liver disease like the PBC and autoimmune hepatitis. We can also see cytopenias akin to what we see in lupus. And in Sjogren disease, we're always concerned about that 14-fold increased risk of lymphoma. And patients, particularly who are very savvy, come up with this in their first visit frequently.
Thank you so much, Sarah. Now, can you please tell us about what biologic therapies are in the pipeline that may in the future address some of the issues you have just described?
Well, I think it's important that we start off with an overview of the pathogenesis of Sjogren's disease. So, I want to start off with the sort of genetic predisposition in our Sjogren's patients. And multiple studies have been done. The largest of these are the GWAS studies done based out of OMRF, but with a lot of contributors and collaborators. And these studies highlight some really interesting genetic predispositions. I think one of the most interesting is the link to HLA. And why this is interesting is because this link to HLA seems to be largely associated with SSA or Rho positive Sjogren disease, which we'll talk about a little more in a bit. But there are other genome wide associated genes that have come up of interest, including STATs, interferon responsive genes, B and T cell related transcripts. And then also, of course, more recently, smaller SNPs like TIC2, TNF related SNPs. So these sort of studies tell us that, some patients have a predisposition to getting Sjogren's, although this genetic link is not 100%. It's only one small piece of the story. So, what else could be happening to cause disease? Let's talk a little bit about Rho or SSA because we mention it a lot in Sjogren disease, and I think it's important to understand what it is in just a brief manner. So, these antibodies to either Rho or SSA were discovered simultaneously in the 1960s and 70s, and they were treated as separate entities for a little while until the late 1970s when it was discovered SSA and Rho represented the same thing. And that's why you'll hear that nomenclature of anti Rho or anti SSA antibodies. Also, anti SSA antibodies in general, but they're the same thing. What can happen is you have some sort of insult, maybe a viral infection or UV light exposure, and this Rho antigen binds to human Y-RNA, can traffic to the cell surface where it forms an apoptotic bleb. And this escapes apoptotic degradation that's usual. And instead, it can be taken up into local dendritic cells or B cells. And there it can act badly and it can stimulate intracellular toll like receptors. And this leads to an initial cytokine cascade that then can lead, unfortunately, to this cycle of inflammation. So once you have cytokines present, that can drive more apoptosis and reveals more intracellular Rho antigen. It also can help epithelial cells act as antigen presenting cells within the salivary gland. This gives T cells their co-stimulatory signal and activates T cells to make more cytokines. Ultimately, this results in this B cell proliferation and predisposition to lymphomagenesis that's very characteristic of Sjogren's disease. All right, so let's focus in a little bit more on the B cells because that's going to be a focus of our talk. This is an example tertiary lymphoid structure wherein there's a central germinal center comprising naive B cells and dendritic cells, surrounded by a T cell rich area at the border. And we also see plasma cells generated within this structure, and it's accumulating at the boundary of the germinal center. And you can see this in a lovely example, both in the schematic, but on the right-hand side, you can see immunohistochemistry showing CD3 positive. These would be our T cells with a B cell predominant enrichment in the center where it would be our germinal center-like structure. And those within them have CD21 follicular dendritic cells. And on the edge, we see our CD138 positive plasma cells. So really nicely illustrated for us to remember what's going on. And what's happening? How does this evolve in Sjogren's? How do we get this? Well, we don't have a lot of data on longitudinal development of these germinal center like structures, but we do have a hypothesis of what's happening. We presume there's an evolution over time in these germinal center like structures. At first, you get these lymphocytic foci that are predominantly T cells in mild disease and B cells in more severe disease, and they can be sort of randomly mixed. Later, we think they segregate into those germinal center like structures we just showed you. And then they can ultimately organize into these lymphoepithelial lesions. And a lymphoepithelial lesion is what it sounds like. So, lymphocytes, lympho, infiltrate into the epithelium of the gland, lymphoepithelium. And why this matters is these lymphoepithelial lesions can be a precursor to multiple lymphoma. They could also be benign. They could be simply associated with another autoimmune disease. But when we see them, we think it might be a step towards this evolution. And lastly, after recurrent antigenic stimulation with cytokine activation, these genetic predispositions, we can get ultimately the multiple lymphoma that's characteristic of Sjögren disease. So, what's happening between T and B cells to activate these B cells and have them ultimately evolve into plasma cells? So, there are several pathways that are really interesting that can be targeted. So, we have the inducible co stimulatory signaling through ICOS and CD40 ligand interactions. These are essential for T and B cell collaboration and drive autoimmunity. So, for example, T cell receptor can bind to MHC class 2 on the B cells, and this triggers T cell expression of CD40 ligand and ICOS. CD40 ligand binds B cells, CD40, and this drives proliferation and differentiation to those plasma cells. ICOS supports the memory T cell response and helps drive this perpetual T cell stimulation. So this combination of TCR, CD40 ligand, ICOS, and cytokines like IL-21 and B cell receptor activation drive these B cells to become these high affinity, long-lived plasma cells that we think drive Sjögren's pathogenesis. Because of this fact, we think targeting these pathways may ultimately help Sjögren's. And this is where we talk about targeting ICOS, CD40. Can we target the B cell itself with anti CD20 or 22? And then targeting cytokines and the B cell receptors that drive B cell activation.
Thank you so much, Sarah, for the very nice overview. Now, Thomas, can you get us up to date with the latest clinical data we have of these emerging biologics, starting with those agents that are further with phase 3 trials?
Thank you so much, Athanasius. And I also have to thank Sarah, who really illustrated very nicely the complexity of the underlying pathogenesis in Sjögren. So the better understanding of pathogenesis led us to new treatment principles. One of them is shown here that has been evaluated in a phase 3 trial. The main cytokines, BAF and APRIL, belonging to the TNF cytokine family, are really very important for driving B cell differentiation and plasma cell survival. And with the ability of telitacicept, which is an antibody that is able to neutralize BAF as well as APRIL simultaneously, that's a very interesting strategy to look into, for example, Sjögren's, which is apparently B cell and plasma cell driven, as nicely illustrated by Sarah. So in a study that has been presented at the last ACR meeting, was conducted in China and altogether 79 research centers in China. They recruited altogether patients with Sjögren's and randomized them into a high dose, 8 milligrams QW, 160 milligram QW, and the placebo in a 1-to-1 randomization. The primary endpoint was change from baseline in ESSDAI, which is European Sjögren's Syndrome Disease Activity Index, and remarkably, the assessment was at week 24. They did a number of additional secondary endpoints, change of baseline very strict at week 48, then the change at least 3 points in the ESSDAI, but they also evaluated the patient-related outcomes, the ESPRI, which comprises pain, fatigue, as well as dryness. Altogether, the study population was quite remarkable. They had, on average, an ESSDAI between 9 to 10, which is really a very severe, or at least very active Sjögren's population. And also the ESSPRI ranged from around 4.9 to 5.1, which is also a very remarkable, a very symptom burden population. The disease duration was usually around 20 years, which is also a very important data point. So when one looks into the primary endpoint, and in particular at week 24, there was a dose-dependent response in the patients. There was almost no response in the placebo group, which I find in particular remarkable, since most of the other trials have shown a substantial response even in the placebo group. But there was a dose response in terms of the change from baseline in ESSDAI, -3 in the low dose, -4.4 in the high dose. But basically, the response was somehow sustained over the subsequent 48 weeks. If one looks into the secondary endpoints, again, dose-response relationship in the more strict change from baseline of at least 3 points. The ESSPRI, again, quite remarkable, showed the dose-response relationship. And again, even in the ESSPRI, I found this really remarkable. There was almost in the placebo response not really any change identified. If one looks into the safety, which is pretty much important because this strategy targets B cells as well as the whole plasma cell compartment. Interestingly, there was not a substantial differentiation between the high dose and the low dose and the placebo group. I found it remarkable that some patients, but also in the placebo, developed pyrexia. And interestingly enough, one would have expected in this half-year study more injection site reactions, but the injection site reactions was only around 40% in the high and low dose, so no difference apparently between the different dosages. But in the placebo group, it was only around 4%. Another strategy, and we are remaining in the universe of BAFF-APRIL, the targeting of the BAFF receptor, which a particular antibody called ianalumab, that targets the BAFF receptor and has a dual mechanism. On the one hand, targeting the BAFF receptor leads to a substantial B-cell depletion, which is a little bit deeper and stronger compared to the CD20 molecules, and at the same time is able to simultaneously block the effects downstream or on the intracellular side of the TNF cytokine B-cell activating factor BAFF. This has been studied now over the last years in different trials, and at the last ACR meeting, the Neptunus trials have been presented. Both are phase 3, so-called registration trials. Neptunus 1 compared 300 milligram subcutaneously once a month over 48 weeks, compared this directly to a placebo group, 137 to 138 patients. The Neptunus 2 was slightly modified. There was, in addition, and the architecture of the trial was quite comparable to Neptunus 1, but there was additional arm studying ianalumab 300 mg only every 3 months, so a quarterly injection. This was more than 500 patients in Neptunus 2. The primary endpoint was the ESSDAI at week 48, so this is an almost 1-year trial. The primary endpoint I mentioned already. There were additional secondary endpoints. This was a quite representative patient population. Time since diagnosis here was required a maximum of 7.5 years. The ESSDAI requirement was at least 5 points, and there needs to be a residual salivary flow rate of at least 0.05 milliliter per minute on stable background conventional synthetic chemotherapy. The change of ESSDAI was the primary endpoint, but before we go into this, the stratification of the different active and placebo arms was quite good, with very minor differences that not easy to stratify. Remarkably, we have about 90 to 95% of the patients being anti-SSA positive. I think that's a pretty much an important marker that we are really having a Sjögren's population in front of us. If one looks into the data of Neptunus 1 and Neptunus 2, Both achieved the primary endpoint at week 48. They could also demonstrate in a further assessment at week 52 that this was statistically significant. The only difference was that the quarterly injection of ianalumab 300 milligrams subcutaneous did not meet the primary endpoint. So apparently it is needed the adequate dosing of at least a monthly 300 milligram ianalumab. If one compares this then with the patient-related or patient global assessment, there was already an early differentiation in the pooled data of Neptunus 1 and Neptunus 2 that they showed a good separation, but there was also a pre-specified analysis that Neptunus 1 and 2 data can be pooled, and there was a differentiation already at half year, week 24, and this was the differentiation from placebo was sustained if one looks into the pooled data of both studies. How does it look like with the other secondary endpoints? Again, the patient global assessment showed some differences. In particular, Neptunus 1 showed more robust differentiation. That might have something to do with the global recruitment of the study. If one looks into the whole list of the secondary endpoints, for example, the Sjögren syndrome symptom diary, as well as ESPRI, the stimulated salivary flow rate, and the FACIT fatigue did not differentiate, but the primary endpoint and the physician's global, at least Neptunus 1 and pooled data, as well as for the patient global and physician global, differentiated. The interesting observation was that patients with residual salivary flow rate above 0.4 milliliter per minute showed a good response, but this could not be demonstrated by patients with lower salivary flow rates. That might have something to do with pre-existing damage, that even the intervention with this biologic did not really lead to an improvement of the salivary flow rate. In terms of the safety profile, this compound has been studied along in several studies now. There was no new safety signal, no opportunistic infection, and I think there was no additional remarkable finding in terms of the safety tableau.
Thank you, Thomas. And what about those biologic with phase 2 results?
So we have a number of very promising compounds in phase 2. First is targeting the CD40 ligand axis. Sarah mentioned that this is very important for B-cell differentiation and the induction of plasma cell programming. In particular, CD40 ligand axis has been studied in the twin study with iscalimab. And the particular cohort, the cohort number 2, compared iscalimab with 600 milligram subcut every other week to placebo. And the interesting finding was simply looking, and this was a symptom burden population, so enriched for patients with high ESPRI, there was a very interesting and I think stable differentiation between placebo and the patients receiving iscalimab. So one may think that this is only related to this compound, but there has been another study targeting the CD40 ligand or CD154 with darzalepa in Sjögren's, and in a similar patient subcohort with an enriched ESPRI symptom burden, they studied over 169 days here, quite comparable to the other study in terms of the length. Again, the changes in the ESPRI. And for me, this population number 2, in this study it was not cohort number 2, but population number 2, again, in addition to the improvements in the ESSDAI, they showed significant improvements in the ESPRI. So I think the strategy of CD40 ligand blockade is quite promising for the high symptom burden population. There are 2 other studies or strategies targeting FcRn, which is a promising strategy in myasthenia gravis and some of the neuroimmunological diseases. Efgartigimod and nipocalimab, a small peptide as well as a monoclonal antibody, are targeting or blocking FcRn activity. They're able to selectively reduce IgG to about 50 to 80%, and there have been 2 studies communicated. The first with efgartigimod in Sjögren's last year at EULAR, showing some improvements in Sjögren's patients, The other study published with nipocalimab in Lancet last year demonstrated a significant improvement in SDI and some improvements at ESPRI over 12 to 24 weeks of exposure. And I think overall, again, the two studies are somehow confirmatory that FcRn blockade is a valuable strategy, which I would have not believed from the get-go, I have to say.
Thank you, Thomas. And now let's move on to discussing how these new therapies may integrate into clinical practice and future management strategies. I have just some questions that we'll probably discuss with Thomas and Sarah that are future challenging things. First, to define phenotypes and endotypes sensitive to specific new treatments. Second, to be able to suggest new biomarkers, not in general, but relevant to a given treatment. And finally, suggest new metrics for treatment responses, taking into consideration both symptoms and objective disease activity.
A lot of the therapies coming down the pipeline obviously target B cells and B cell activation and differentiation. And so logically, I might hypothesize that the patients who will be most sensitive to these therapies will have a B cell immunologic feature of some kind, whether it's high IgG, rheumatoid factor peripherally, or whether there's a B cell predominance or germinal center like structure presence in their labial salivary glands. That would be what I would hypothesize, but of course, proof will be in deployment. And so similarly, we may use biomarkers akin to that or more specific ones like BAFF levels peripherally. I don't know how that will work in the long term. And then metrics for treatment response. That is an area of particular interest of mine. So you can see there's large placebo response in the ESPRI and the SDI. Should we be using something more objective, and what's reasonable to use clinically, I think is yet to be determined. But I do think things like salivary gland ultrasound hold promise as a potential way, maybe, to determine if there's response at the bedside.
Thank you. Thank you so much, Sarah. Thomas?
I simply wanted to add that most of the current studies are really selecting patients with typical SSA positivity. That's an enrichment of the type 1 interferon signature patients, mainly also comprising extraglandular disease. What we do not know in the moment, and this is something beyond the clinical studies we need to find out, how the patients being so-called seronegative, but still have a typical or characteristic salivary gland biopsy, how they will perform. I think that's already one strategy, using one biomarker where we need to learn more beyond the clinical studies. And I think we also need to identify certain patient profiles according to the organ manifestations, what Sarah illustrated at the beginning, whether one or the other responds or does not respond, similar like in other diseases.
Thank you, Thomas. I think that the overarching conclusion is that now we're in a much better situation compared with what we had 5 years ago. Sjögren's disease is a multisystemic chronic autoimmune disorder with multiple clinical phenotypes, a variety of operating inflammatory mechanisms, and variable course and outcome. The community has to remember that different medical specialties, including rheumatologists, internists, ophthalmologists, oral medicine specialists, obstetricians, primary care physicians, can see patients with Sjögren's disease, and therefore the basic elements and metrics of the disease should be communicated with these specialties. The doctors, the physicians, should be aware for recent advances in diagnosis and treatment. Current unmet needs include faster diagnosis, psychosocial, functional, and financial burden on patients, as well as safe and efficacious therapies for both objective and subjective findings. Large phase 3 trials targeting B cell production and activation and co-stimulation, telitacicept and ianalumab, has shown positive results. But also phase 2 trials targeting B cells, co-stimulation, FcRns, show also promising results. And with this conclusion, I would like to thank Sarah and Thomas for this great discussion. And thank you for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.
This program was presented by Medscape Education Global.